Recently, I have been asked by patients and providers why I have preference using hypochlorous acids over the sodium hypochlorite solution. For those who know me from before, you know I'm not fond of memorizing brand names, but for the sake of better understanding of our topic today, when we say hypochlorous acid solution, we are referring to the Vashe wound solution as an example. And when we say sodium hypochlorite, we are referring to the like brand names like the Anasept or the Dakin solution. And for those of you whom I have worked in the past watching this, you could attest that I had used Anasept as a cleansing agent. I tell you right now that as an evidence-based clinician, it is okay to change our mind. Science is an evolving process, and um, when we follow science, our patients will win the battle. That's my humble opinion. So, like what I said earlier, it is not my intention to promote one product and put down the other product. We're all educated clinicians here and we have free will to choose what is the best for our patient. If after watching this video, your preference is still going to be different from mine, that is okay. In a democracy, we have a free market place of ideas. So as long as your heart is for the interest of the patient, then I suggest that we should still kind of be good friends. There are so many truths, though. Okay, your truth, my truth, his truth, her truth. But as long as the truth is evidence based, let's bring them on the discussion table. We should not forget that we as clinicians uh, we should imagine ourselves standing, forming a circle, and the patient is at the center of that circle, and we are all looking at the patient, not to each other. Okay, so wound care indeed is a team approach, and the approach should be evidence based so it has a solid foundation that should boil down to great clinical outcomes. So my primary goals for this lecture is to describe the biochemical differences between the two solutions, and I will tell you why I choose one from the other, and let's review the current evidence and practice regarding this topic, and then I will make my summary and recommendation. So this is an example of an order. So it says cleanse wound on the left lower leg with Deacon's solutions, every dressing change. And it also specifies the frequency, with it's like 3 times a day. And also it says may use Anasept as a substitute. Actually, it looks like it's a good order to me, like the way it's written, because it has the location of the wound, it has the specific brand or specific product to use, and it also has a frequency, and also stipulates or specify the substitute product, just in case the taken solution is not there. But if, in your opinion, as a clinician, you think that taken solution is not the order that you're gonna pick, so do you think that this is a bad order? You're gonna label this as a bad order? In my opinion, it's not necessarily a bad order, but in my opinion, will there be a better product, or will there be a better uh, order? I mean, yes, to be used to the patient. So, if you think so, you should equip yourself with good reasons, then label this as a questionable order for you, and then communicate that to the prescriber. In your communication, you have to make sure that you are respectful, you should be scientific, factual, and you should establish an evidence based argument, not anecdotal. Let's stop the cycle. Most of the time, the prescriber may not be updated. Wound care is a specialty of its own. So, how would a physician know everything, right? If the approach is right, If the communication approach is right, I believe that the response will be right as well. So make the patient win, not you or the doctor in this type of situation. By the way, I've been talking a lot about evidence-based practice already. So what does evidence-based practice mean to you? So I don't intend to lecture on a two-semester course in evidence-based practice, but I just wanted to make sure that we're on the same page when we say evidence-based practice. I can tell you right now that as an evidence-based clinician, you should provide care that is grounded in scientific research. It should be guided by clinical expertise and ultimately directed by the patient's individual values and circumstances. So it's like a triangle. So what um, what is your expert opinion about this this thing? What will be a good treatment for this? What does the textbook or the expert are saying about it? So you're gonna elevate it higher and say, so what is the scientific research are saying in vitro, in vivo, ex vivo, this kind of stuff. And after that, you're gonna bring it like this is the patient now. What are the unique patient circumstances? What are you looking at the patient? What are the characteristics of the wound? What are the comorbidities for the patient? What would the patient like? Okay, so what are the patient choices? So you have to put all those together, and in that way, you're now an evidence-based clinician, um, uh, basically speaking. Okay, so if you Google a question and an article pops out to your rescue, do you know how to appraise the paper? Okay, don't believe everything because don't believe everything that you should be able to appraise the literature that you're reading. Okay, so now how is this applicable to to what we're discussing right now? So our words are gold to our patients. So um, if the evidence is clear that one intervention is better than the other, we need to share this to our patients, colleagues, and also the prescribers. This enhance the quality and credibility of our services. So if we think this way, the patient will enjoy the best clinical outcome. The interventions that we were doing yesterday may not be necessarily wrong, but the question is that, like what I said earlier, is there a better and most efficacious and most efficient way in treating this patient? Or like, is there a better product? So we must choose, right? We must choose. In the real world, we find ourselves like taking a multiple choice examination when we're confronted with unique patient circumstances. And there are so many options that we can do for the patients, and these options are actually good options. However, we must, like taking an exam. It's like a multiple choice exam. So, what is the best choice? What is the best intervention for this patient? Okay, so let's go further. So in this slide, you would see the structure, the chemical structure of Vash versus the structure of the Anasept or the Dakin solution. So if you would note that, of course, we have the chloride, we have the oxygen and the hydrogen. For the sodium hypochlorite, you would notice that it's now deprotonated. Okay, so and they're both inorganic compounds. And this is the chemical formula for both. This is the hypochlorous acid and sodium hypochlorous. What I want you to remember, okay, is the pH. Always remember that for the hypochlorous acid or the VASH solution, the pH is between 5 and 6, and for the sodium hypochlorite, it's a lot higher is the alkaline side. Okay, so it's actually between 10 and 13. So now you would, I'm going to make a lot of emphasis on the importance of the pH in wound healing as we go on with the discussion. Anyway, if you're a clinician or if you are a patient, which one do you prefer? A product that has a milder odor or a product that has strong odor? When I was still using Anasept at that time, that was before the pandemic, uh, we don't have a lot of N95 at that time. I'm just using the regular face mask, and it's the face mask is not actually enough to shield me from the strong odor of the Anasept. Anyway, side effect wise, there's a great body of evidence that hypochlorous acid is actually non-toxic, it's non-irritating. And like what I said, for the Anasept in the Dakin solution, uh, one of the side effects is people get nauseous, and they're also irritating to the skin and the eyes. In fact, the label says keep away from the children, and you have to use it in well ventilated areas. And hypochlorous acid, it's safe if ingested. If you accidentally ingest it, they're saying it's safe in small amount. So then I will tell you why later as we go on to the next slide. So stay with me, and we have a lot of uh, great things to talk about. Okay. So, if you're a physician or a nurse watching this, let me just take you back to the sweet memories of your biochemistry class. However, if you're a therapist watching this, please follow me, as you may have not encountered this biochemistry pathway during your formal education. Um, what is happening during the acute phase of inflammation or during the acute inflammatory phase of wound healing? So you heard about phagocytosis, correct? You know that the goal of the acute inflammatory phase is to debride the wound, to eliminate bacteria, to prevent infection. So phagocytosis must happen not only during the acute inflammatory phase of wound healing. This is happening every single time when the immune system recognizes a foreign invader. So let's talk about phagocytosis. So it starts with the recognition and attachment of invading bacteria to neutrophils or the macrophages. So the bacteria needs to be recognized first and by the immune system. Just like me, you can recognize me by um, just listening to my foreign accent. You know that English is not my native language, right? So now after the recognition, the bacteria will be attached to the neutrophils into the macrophages. And then the bacterium is being engulfed through the process, we call it endocytosis. It will now be incorporated into phagosome, then into phagolysosome. Okay, here, let me see if I can use my pointer. So that is the bacterium there, and then it's being recognized and it's attached to the membrane to a ligand mechanism, and then it will be engulfed through the process of endocytosis, and then it will now be incorporated into phagosome and then internalized into what we call phagolysosomes with the attachment to lysosome. Okay, now after this, the molecular oxygen readily available in the surrounding will now be converted into superoxide to the action of this very important enzyme. We call it the NADPH oxidase. This conversion of molecular oxygen is robust to peroxide, and we call it the respiratory burst. This is very important, while in fact, there is a genetic condition when people cannot express this enzyme. The deficiency and the NADPH oxidase causes a lot of problem, and it's been our discussion for today. Anyway, after the production of superoxide, the superoxide will now be converted into hydrogen peroxide spontaneously or through the action of an enzyme. We call it the superoxide dismutase. So this is dismutated into peroxide. Now follow me here. Okay, in the presence of chloride and through the action of this enzyme myeloperoxidase, this is actually a lysosomal enzyme. The hydrogen peroxide now will be converted into hypochlorous acid. Okay, now boom, we you now know that hypochlorous acid is naturally produced by our immune system to kill bacteria. This is a very powerful or very potent bacterial killer. Okay, so now that is the oxidative or oxygen dependent pathway of bacterial killing in the body. By the way, let me mention that during this process, the environment here is acidic. The pH is low because the protons are being pumped into the membrane of the phagosome so that there will be more production of uh, hypochlorous acid because you need a lot of oxygen to produce hypochlorous acid. Okay, so that's it. So, oh, by the way, let me just go ahead and summarize here. So, let me see if this is your, okay, let's see. If this is your molecular oxygen available, okay, it will be converted into a superoxide um, species. And then this is through the action of your NAD, pH, pH oxidase is an enzyme, okay? Oxidase. All right. Oh, I am having difficulty writing this in. And then this superoxide will be converted into peroxide. All right, into peroxide, and to the this one will be converted into hypochlorous acid um, through the action of the enzyme myeloperoxidase in the presence of chloride. Okay, now that's how we produce this very potent bacterial killer in the body. We call it hypochlorous acid. All right, so let's keep going. So the next mechanism is the oxygen independent pathway. Here, the killing is through enzymatic activity. So remember that all you need to do here is to have a hostile environment for this enzyme to work. So there are numerous of them, but my favorite is the lysozyme. So you need a low pH, and in fact, the phagolysosome pH drops to between 4 and 5, this being the optimal pH for the action of this enzyme. So the take-home lesson for these two pathways is that the oxygen-dependent mechanism in killing bacteria uh, produces hypochlorous acid, which is a very powerful bacterial killer. And the other arm is the enzymatic arm all you need to do is to have a hostile or low pH environment, and these enzymes will be activated, and the bacteria could be killed. So let's keep moving on. So at this point, please remember that there are four overlapping phases of wound healing. First is the hemostasis, followed by the inflammatory phase, the proliferative phase, um, and the remodeling phase. So now, if this is intact skin, you'd know that the pH, okay, at the surface of the skin is 5.5 and below is 7.4. Now, uh, the normal skin with intact keratinized epidermis, like what I said, has a pH of 5.5, and this is due to the secretion of the sweat in the sebaceous glands and also the presence of fatty acid and other proteins. Okay, so after the clot formation, or after the clot is formed due to the disruption of arterial and venous supply, um, this reduces the oxygen supply in the wound environment. So this, remember that the purpose of the hemostasis phase is uh, to produce the clot and also to prevent further bleeding. So there is a massive vasoconstriction. So what happens there is that there is decrease in the oxygen supply in the wound environment that would lead the shift from an aerobic metabolism into anaerobic metabolism that will lead to the buildup of lactic acid, and this buildup of lactic acid reduces the pH of the wound into 6. This is actually the initial wound fluid pH. So let me just write it down. It's 6. Okay. Now that's the initial pH of the wound fluid. Now, in the inflammatory phase, the neutrophils and macrophages generate reactive oxygen species. Okay, I already showed you the pathway earlier. There's a production of hydrogen peroxide and of hypochlorous acid, and this lowers the wound fluid to a pH of 5. So it's more acidic. Okay, so let me just write that down. 5. See. There you go. Now, in the proliferative phase of healing, um, the vascular endothelial cells generate new capillaries. So remember that there will be now a process of angiogenesis. There's a granulation tissue formation. There's a proliferation of the fibroblasts. There's a migration of the fibroblasts into the wound matrix. And there's a production or a making of a new collagen. And also, in fact, some of this collagen differentiate into what we call myofibroblasts that is responsible for the wound contraction. These together increase the wound fluid into 7. Okay, so the pH now will become more on the neutral side. Okay, now the as the healing progresses, remember that especially if this is a full thickness wound, okay, the what you call this, the hair follicles are no longer there, so your body will be relying on the adjacent intact skin, okay, and especially the basal layer of the adjacent intact skin and in the bulbs region of the hair follicles. They will grow rapidly and produce these epithelial cells, and these epithelial cells will migrate into the new scar matrix to resurface the matrix. Okay, so this together helps return the pH to 5.5. So 5. 0.5. So studies had shown actually that a full healed wound has an epidermis pH of 5.5 and a repaired dermis of 7.4. Okay, so let's keep moving on. So that's, oh, by the way, before we leave this slide, that is the, I just showed you how pH changes during the different phases of healing. Okay, and then you know that this, okay, in this phase, okay, the pH must drop in order for bacterial cleaning or phagocyte, not phagocytosis, for the final phase of bacterial killing could happen either through an oxygen dependent or an oxygen dependent mechanisms. So why is it extremely important to have a balanced pH on the acidic side? Um, the resident bacterial flora remain attached and preserved to the skin if you have a normal pH which is on the acidic side. Okay, when the pH is, let me see the pointer. So when the pH is disrupted and becomes alkaline, okay, what happens? See here, this allows the dispersal of bacteria from the skin and growth of pathogenic bacteria. So this allows entry, okay, and contamination of acute wounds. So if you have acute surgical wounds, the disruption of the pH actually allows the entry of bacteria that would contaminate the wound, that could lead to colonization and, of course, impaired healing. So, on the side note, remember that all wounds are contaminated, but they would heal. When they are critically colonized, even though there's no sign and symptoms of infection, sometimes this wound will not show any sign of healing because they are critically colonized. Now, it is reported in the literature that bacterial colonization may contribute to the shift toward an alkaline pH, and the pathogenic bacteria has preference to grow at a high pH environment. So that is the importance of having an acidic mantle, okay, versus the alkaline skin environment. The reason why the bacteria cannot penetrate, cannot attack, cannot enter the skin because it's maintained by a pH that is more on the acidic side. And once the pH is disrupted, this would allow the penetration or the entry of this bacteria or the dispersal of the bacteria, the resident flora of the skin. And they would allow the growth of pathogens. And this bacterial metabolism would also increase the alkalinity of the environment that further encourage the growth of other pathogenic bacteria. That is extremely important that we have an acidic mantle on the skin versus an alkaline skin environment. Okay? So, ladies and gentlemen, let's do a literature review about the topic that we are having at hand at this point. So, there are two papers that I was able to take a peek, and there's one thing that I can tell you. Bacterial growth is correlated to increasing pH. So this is the optimum pH for this for a bacteria to grow. I selected these four bacteria because they're the most commonly isolated bacteria during a wound culture. So the studies between these two papers are almost identical. And also the biofilm production is correlated to a higher pH wound environment. So anyone knows what's biofilm? If you don't know what's biofilm, probably we're going to be doing another lecture, another blog about biofilm, um, so that everybody would understand what is biofilm. What I can tell you right now is that the pH of the Vashe solution is 5.5, and the pH of Anasept, the 0.57% concentration is 7 to 10, and the pH of acetic acid is 0.25, the 0.25%, I'm sorry, acetic acid is between 2.8 to 3.4. So remember when we're talking about the skin, okay, 5.5 is normal pH of the skin. So so it is good, right? So it mimics that normal acidity of the skin. So this is one of the reasons why I like this product. Okay, now Anasept, you know that it's that the higher you go, the more that you will more likely allow a growth of bacteria. So there's also a paper that I have seen that Anasept is actually effective in killing bacteria. How I mean, I'm sorry. What did I say? Um, the Anasept is harmless, okay, or the cytotoxicity is not that all bad. And actually, they're saying it's harmless. But my problem and my issue is that look at this pH, it's 7 to 10. So probably that is the reason why I had some patients in the past, especially with those patients with the chronic wounds presenting as a consequence or a complication of lymphedema. I have a lot of patients that I've been using Anasept in the past that uh, kept getting infected, okay, despite of the fact that I'm only already using this. So I could have an assumption. It's my only assumption on the clinical side. Well, I don't have a quantitative data to tell you that my assumption is true, but you're just looking at this science or logic behind that the pH of Anasept is actually high, more on the alkaline side. That it's even though they are saying that it is not cytotoxic, but actually it's it could allow of microorganism because of its high pH. For acetic acid, it's actually one of my favorite. I've seen it work, especially for only on some occasions. Don't get me wrong. Okay, so if I see that the wound is draining, greenish, it has a greenish discharge. I have a high index of suspicion that the wound is colonized, critically colonized or infected with Pseudomonas, and I will start flushing right away or cleansing the wound right away with acetic acid. And true enough, when the culture is back, it has a heavy growth of Pseudomonas, and I only use this uh, maximum of 2 shots, but most of the time I only do it like flush it and really cleanse the wound once. Okay, once only, because look this. Okay, all the literatures that I have reviewed, it doesn't matter what uh, the concentration would be, it's still cytotoxic to human fibroblasts. So I only use it's like a big gun for me. I just get the big gun. It's like psh, you spray it, and sometimes I just close my eyes because I know that there will be some collateral damage. But I would save or robustly control the infection, especially if the wound is infected with Pseudomonas. Okay, now, what is really the problem in chronic wounds? Why is it that chronic wounds are difficult to heal? Okay, so there are two things. You have elevated bioburden, and this bioburden drives the wound pH uh, uh, to the alkaline side. So it's actually most of the chronic wounds, they have a pH of 8.5 on average. So when you say bioburden, remember there that we have this planktonic bacteria, and we also have this biofilm. So this bacteria are attached to the surface, and they cannot be accessed our uh, by oral antibiotics. So remember, in in your pharmacology class, in our pharmacology class, that antibiotic can be can kill bacteria only those who are free floating, or we call it planktonic bacteria, and it is very hard to impossible for them to be able to penetrate and kill this bacteria that is attached to the surface in a biofilm. Okay, so the um, uh, the reason um, why the other problem here is that uh, there's an impaired production of hypochlorous acid. Okay, so there's a decreased uh, production of hypochlorous acid, and this is one of the reasons why it's very hard uh, for the body to eradicate bacteria. Because remember earlier in our discussion that for the production of hypochlorous acid, it has to happen in a low pH or acidic environment, because you need the protons for you to produce a lot of this hypochlorous acid. Okay, now your goal of treatment then in chronic wounds will be to decrease the bioburden and to drop the pH. Okay, so let's keep going. So, ladies and gentlemen, so this graph shows you the dissociation curve of hypochlorous acid in a solution. So, look at the pKa of hypochlorous acid is 7.5. So, as you increase the pH, like what's happening in a hypochlorite solution, the pH of 10, okay, um, if you look at this graph, the concentration of hypochlorous acid is zero, nada, none. So because hypochlorous acid is already deprotonated to the hypochlorite acid side. So I want to mention also that the hypochlorous oxidation potential is twice as the hypochlorite anion. So its ability to kill bacteria is twice as effective as the hypochlorite uh, anion. So this work by Wang et al. Shows you a graph that demonstrates the time to kill um, data for hypochlorous acid, and as compared to hypochlorite acid to your hydrogen peroxide. So if you notice, the hypochlorous acid has a very fast and very robust and very abrupt, very sudden. It's really a fast-acting mechanism to kill bacteria, as contrast to the other products or other solutions. So the time to kill, by the way, is an in vitro measure of how fast a given antimicrobial solution could kill a test bacteria. So in this result, you see that hypochlorous acid is very fast acting. Okay, now, unlike the other antimicrobial like silver or the provident iodine like the iodosorb, for example, they are um, a little bit long acting, but hypochlorous acid, once you drop it, okay, looking at this data, they could kill the target organism, microorganism, so fast. Okay. Now, this other graph is the minimum bactericidal concentration. What is this? It is the lowest concentration of an antibacterial agent required to kill a particular bacterium. So you want this to be low, okay? Because the lower it is, the safer it is. Because if you increase this number, it's more that you expect more cytotoxicity to the human fibroblast or to the human cells. So if comparing between hypochlorous and a hypochlorite acid, this data tell us how safer hypochlorous acid versus the hypochlorite acid. Okay, this is the Vash, this is the Anasept or Dakins. Okay, so this slide shows the relative therapeutic index of these two solutions, the peroxide, the hypochlorite acid, and hypochlorous acid. And by the way, uh, let me just tell you that the therapeutic index is the quantitative measurement of the relative safety of a drug or a solution. In pharmacology, this is the ratio that compares the blood concentration at which a drug becomes toxic and the concentration at which the drug is effective. So, the larger the therapeutic index, the safer the solution is. And if the therapeutic index is low or small, okay, the solution must be dosed carefully, and the person receiving the drug or the solution should be monitored closely for any signs of toxicity. So if you can see in this drug, where there's these three organisms here that being uh, studied, uh, the therapeutic index of the hypochlorous acid is high on these three organisms compared to the hypochlorite and the hydrogen peroxide. So therefore, from this graph, we can infer that the safety of hypochlorous acid is um, very much appreciated as compared to the two solutions. Although, look at this, I like the fact that the hypochlorous acid, I mean hypochlorite acid or the Dakins or the Anasept also have a high therapeutic index um, with Pseudomonas aeruginosa. Okay, so I hope that makes sense. So, further searching the literature, I came across with these two studies in here. The first one is the in vitro study, uh, looking at, they were trying to look at the cell viability after 6 hours of exposure to the VAS solution, the Anasept, and also uh, the hydrogen peroxide. So anyway, as you can see in here, at 0 to 10 concentration, look at the cell viability of the VAS solution. It is ranging from 70 to 80 um, cell viability. Okay, as compared to Anacept, look how the viability is like low. It's a lot lower. Okay, compared to the Vash. It's like on the 22 to 40 cell viability. Okay, so this would tell us that that in terms of the cytotoxicity, Anasept is way cytotoxic than than the Vash solution. Another thing, and another interesting paper that um, I have seen is the effect of Vash on biofilm bacteria. So, like what I said earlier, we have the planktonic bacteria and also the bacteria that is attached to the surface or to a biofilm. And you know that our antibiotic can only access or can only kill the one that's a free floating. We call it the planktonic bacteria. So, in this study, uh, further, they're saying that there is a decreased inflammation or inflammatory response. Remember earlier, uh, I already mentioned that most of our chronic wounds are stuck to the chronic inflammatory phase where there is continuous production of our enzymes like the proteases and whatnot, and this constantly uh, creating or releasing this enzyme that is destructive to the matrix, to the extracellular matrix. That is the reason why sometimes it's so hard for the wound base to grow a granulation tissue. Okay, so they're saying that with the use of hypochlorous acid, it decreases or this inflammation response by removing the biofilm. You know why? Biofilm actually they have specific extra cellular DNA that can easily get recognized by our immune system. So because of this DNA that produced by this biofilm that is recognizable by the immune system, the immune system keep responding with that specific DNA that the biofilm uh, are able to express. Therefore, it keeps the wound into the chronic inflammatory response. So, by eradicating or removing the biofilm by the action of the VASH or the hypochlorous acid solution, you can reduce or eliminate this inflammatory response and you can start growing granulation tissue and the wound would go to the proliferative phase of healing until it goes to the last phase of healing. So interesting, isn't it? So I just want to show you this abstract about the in vitro um, microbicidal antibioform and cytotoxic effects of different commercial antiseptics. So in vitro, a variety of antiseptic were analyzed to see their effectiveness against biofilm formation and removal and the cytotoxicity of these agents to human fibroblasts. So they found out that chlorine-releasing agents exhibited immediate antibiofilm effects in the short term with lesser toxicity than agents prepared from more stable compounds such as biguanide. So interestingly, hypochlorous acid was effective in preventing biofilm formation within a short period of time and showed a virtually no toxicity. This is according to this study. Okay, so one of my favorite journals in wound care is this journal, that Today's Wound Clinic, and this was published. This is a work of Robson, and I like this um, two graph here showing how hypochlorous acid um, could dramatically and abruptly decrease both the number of bacteria and also disrupting the polysaccharide component that is found in biofilm. So they're saying that it's maybe a very good solution to assist a hard to heal wound because of its effect on the biofilm. Okay, so let's wrap up. By the way, I work in an outpatient wound clinic, and I only have like four solutions there right now. So I have stocks of normal saline. I use it for irrigation, for mechanical debridement, and whatnot. Um, um, Obviously, I use Vash as my regular cleanser, and I have a protocol. I use 5 minute soaking, so I saturate the gauze and place it directly on top of the wound for 5 minutes. But I instruct my patients to do it for 10 minutes at home. So if I know that the wound is kind of dirty, so I tell them to do it every single day. And then of course, you reduce the dressing frequency as the wound improves. And I do not pat dry. I just leave it there. Okay, unlike the other solutions that I usually pat dry, but for this I don't. I just leave it there, and I use VAS in conjunction to other antimicrobial dressings or topicals. Remember that this would significantly, like what the studies that we already talked about, it significantly or it has a fast acting effect. That's the term that I was trying to say, and I use it for both acute and chronic wounds. Why acute wounds? Because there's a growing body of knowledge in the literature that after a wound is debrided in the hospital, like I usually see them after they're being debrided in the hospital, that in 3 days you can form biofilm in 3 days, and I it is my clinical opinion that if we use Vash early um, with this type of patients, and we may be able to eradicate or reduce the risk or even prevent the formation of biofilm, which they can easily form after 3 days. So I am glad that I never had any. I never had any, and this is one of the things that I'm excited about to tell you. We form clinical biases through our experiences, and sometimes if we see it happening, like is it coincidence, then you have to look it up, like what is the expert opinion, what are the experts talking about it, like what is the biochemistry uh, of this product, and then look at the experiments, look at the in vitro, the in vivo, the ex vivo, look at the literature to elevate um, you know, your argument about your preference to a certain product, and you also uh, look how the patient preference. They love Bash because it does not irritate them. It's not irritating, and also I love it because I usually don't experience headache after work. Before, when I was using this, that, at the end of my shift, because I work like 10 hours a day, at the end of my shift I have like, I feel no shitting, I have to wash my face and everything like that. So that is the reason why my preference is, I would say, clinical bias, because I have my own reasoning. How about you? So, like what I said earlier, if you think otherwise, we're still good friends as long as our intention is to find out the best for our patients. I still have acetic acid in my office, in my clinic. You know why? I find it I don't know if it's still anecdotal, or because the literature is very controversial about acetic acid, but every time I see a greenish discoloration, one or two application, the greenish discoloration is gone. and sometimes I don't even have to culture the wounds. Most of the time, when I see that greenish discoloration and I send a culture, and at the same time, I cleanse the wound with acetic acid. With two applications, the greenish discoloration is gone, culture is back. It's positive for Pseudomonas, and there's no more clinical sign of infection. Or by the way, the only reason why I send or I culture a wound is when I am uh, gearing towards asking the referring provider to prescribe for antibiotic. But otherwise, uh, these local measures that we do in the clinical side, in my opinion, they usually suffice to control the bioburden. Um, anyway, why I have Dakin solution still in my cabinet, because it is very effective in my opinion and also in my clinical experience for so many years. So when the wound stinks, when the wound is really, really presenting with a foul odor, I find it very effective in controlling odor. I know that there is a collateral damage. That's the reason why I don't usually use it. The most that I would do is two applications, but most of the time, once I irrigate and cleanse the wound, stinking wound, uh, uh, with Deacon solution with just one application, the next time they come, I don't uh, see that, or I don't smell the foul odor anymore. So that is my usual protocol in my current practice at this time. Okay, so to answer the question, when to use Vash, I use it all the time. Okay, so do I use it for prophylaxis? Um, Usually, in my opinion, because biofilm can form, you know, anytime. Um, yes, I don't know if you call it prophylaxis, but I think bioburden control. That's the way I see it. Chronic wounds. Why did they become chronic? Why are they stuck in the chronic inflammatory phase? So we need to manage, like what we said, the bioburden, and we have to reduce the pH. So uh, that's why for me it's very useful to on my daily practice. Okay. All right, so let's wrap up. So to summarize this very long discussion, please, like what I said, if you think the other way, I hope that we're still going to be good friends after this discussion. Anyway, and to summarize my point, the reason why I stopped using Anasept and I now use Vash as my primary cleansing solution in my practice, because I've the clinical outcome is very good in my for the last 3 years that I've been uh, using Vash as my primary cleansing agent. I have never seen any bad case of wound infection while I'm seeing patient. I've seen these acute wounds heal fast and the chronic wounds um, healing really well, more than I anticipated. So I like what I said, I'm not here to promote this particular product, but I'm here to share my clinical experience. Patients loves it. They have a very good feedback about it. I never heard anybody complaining about irritation, stinging, and everything like that. And I love it myself. I never had any headache after my shift after using this solution primarily to my patient. By the way, I see like 14 to 16 patients in a day while I work 10 hours in a shift. Anyway, although I don't have a quantitative data to show, um, because I work in a huge company and they have a very, very high standard as far as patients' confidentiality and everything that like that. I have not figured out yet how to make my own, you know, clinical data, or probably in the future I would ask my company if I will do my own research in my setup. That would be that would be great. And just to summarize, always remember that hypochlorous acid has antibiofilm activity, and the reason why these wounds go chronic because of biofilm. And don't when you speak of biofilm, don't only think about chronic wounds. They can also form in an acute wounds as early as 3 days. That's according to the literature. And also, hypochlorous acid is more effective than hypochlorite in killing bacteria. That was already proven in the literature. And hypochlorous acid has supportive pH of 5.5, and this solution does not interact with other antimicrobials, so I can still use it with my silver dressing, my iodosorb, and whatnot, Medi honey, and also I can use Santil with Vashe solution with no problem. So hypochlorite, in the other hand, like the Anasept or the Dakins, is controversially cytotoxic, and well, there's also some literature saying that they are very safe, they are not cytotoxic, and but just looking at how the effect of pH, okay, on the wound, I would say that it may be cytotoxic, or it may actually encourage the growth of bacteria, because like what we've seen earlier, that bacteria grow more on the alkaline side. Okay, by the way, I always look at what we call patient choice. Patients are happy about it, they are healing, they are improving, and uh, I love it, and I can say that I can defend, because I was able to establish a scientific basis why I have a clinical preference using this product more than that product. All right, so that's all, and thank you for listening, and I hope that you learned something. If you have any question or have seen something in error, it wasn't my intention. Please leave a comment in the comment section so that we can improve our discussion. Uh, Always remember, if there's a will, there's a way. Thank you very much.